Welcome, my dear colleagues, my dear attendants. It's a Fabre Symposium. I will want to welcome my dear Professor Elgin, Professor Dr. Ahmed Hassan Abdelaziz, to speak about the odds in the HER2-positive breast cancer patient in early cases. Dr. Ahmed.
Assalamu alaikum.
Please, colleagues, can you sit down, please? Because we are lack of time. We want to start symposium now.
Assalamu alaikum. I'd like to thank Pierre for inviting me to give this talk. This is a symposium. It's a sponsored talk. Okay? And over the next 15 minutes, I will be giving some rationale for why we're doing what we're doing at the moment or at this stage of cancer therapy, particularly HER2-positive early breast cancer patients, and where we can position or where we can fit in a new molecule, which is new to us probably in Egypt. However, it's not very new elsewhere. So just a bit of a background. So HER2-positive breast cancer, it constitutes roughly 20 to 25% of our breast cancer patients. We know that HER2-positive breast cancer patients tend to have a higher risk of recurrence and higher propensity to metastasize to lymph node and distant cells. Okay? That's why they require a different way of therapy. They are driven by the mutation in the overexpression in the HER2 gene. And first, I'd like to give credit to Dr. Hamdi Abdelaziz for this slide. I've taken his permission to use this slide because it demonstrates beautifully the progress in management of HER2 after the development of trastuzumab molecule. 2 decades ago, we realized the importance of blocking the HER2 gene, hence improving the outcome, improving the risk of recurrence, reducing the risk of recurrence, improving the disease-free survival, and overall survival. However, as you can see from the triangle on the top, despite giving adequate chemotherapy and adjuvant trastuzumab, we learned from the NSABP, from the HERA trial, from the BCRG, that there is still around a quarter of patients will experience recurrence of breast cancer despite blocking the HER2 and giving chemotherapy. And we've also noticed that later with longer follow-up from a study like the BCRG-06, that patients with node positivity are at higher stakes. And the more lymph node involvement, the higher the risk of recurrence is up to 40% of patients who will unfortunately have disease recurrence, and these patients will eventually die most probably of breast cancer. So around 40% of patients are still at risk, and these patients, we need to optimize their outcomes. How we can optimize their outcomes and what is the significance of these patients. They are very significant to our Egyptian population. We've recently published a meta-analysis where we pooled the results of 26 clinical trials from across Egypt. If you look at, for example, the bottom study here is coming from Ain Shams, contributed with 1,600 patients. But we pooled all of the literature from the NTI, from Upper Egypt, from Mansoura, and we looked at the patients presenting with stage 3, patients with heavy lymph node involvement. And it was not a surprise to find a consistent finding that 45% of Egyptian breast cancer patients attending with stage 3. These are the patients in the BCRG who are at very high risk of cancer recurrence. Many of these patients actually will not be cured despite doing optimal surgery, giving optimal radiotherapy, anti-HER2, and chemotherapy. And we looked at the literature and we find actually that our figures are consistent with the international literature. So HER2 positive in the Egyptian patients is 21% in the meta-analysis, and in the very recent presentation in the ESMO, where we presented the results of the 2 years of the National Breast Cancer Program, we found that the rate of HER2 positive was 22, almost 23%, which is in keeping with the Western literature. So we're not very different. We are different in the initial stage of presentation of patients. And because we were not doing very well in terms of preventing recurrences, there were different efforts. And the early efforts looked at extending the trastuzumab period for 2 years, the HERA trial. And this was an absolute failure, no improvement, and did not make any difference. In fact, it increased the toxicity, increased the cost of treatment, but no positive outcomes. Then we've seen the affinity results. What if we do dual anti-HER2 blockade, particularly in patients who are at higher risk? And we've seen very modest improvements in invasive disease-free survival and distant disease-free survival, which were not very encouraging, not very convincing. But when we looked at the node-positive patients on the right side of the screen, we've seen a hazard ratio of 0.72, 30% improvement in distant disease-free survival. The absolute difference was around 5%, and this was convincing. And hence, pertuzumab was introduced in the armamentarium of adjuvant therapies in breast cancer patients. But in around 2014, we had a seminal paper by Cortazar and his group where they published the results of the impact of pathological complete response on disease-free survival, event-free survival, and overall survival. And at that point, we've learned that if you offer neoadjuvant treatment and you achieve pathological complete response, this would translate into better event-free survival and overall survival. And we had resistance for a long time from surgeons coming say, oh, we don't want to miss the boat giving neoadjuvant treatments, and patients become unwell, and then we don't do surgery, let's do surgery up front. But then we had convincing data to support us doing what we're doing, that we should be considering neoadjuvant treatment in many of our breast cancer patients. If you look at the HER2 subgroup of patients, we've seen that neoadjuvant PCR meant improvement in event-free survival and overall survival. So many studies started to work on this dimension, trying to improve the PCR. And we've seen gradual improvements over the past 2 decades. How we can improve this? Shall we remove the anthracyclines? Shall we extend the duration of chemotherapy? Shall we add pertuzumab, dual anti-HER2? Anyway, to cut a long story short, over a period of 2 decades, we've learned that the more chemotherapy you give, the more anti-HER2 blockade you offer. If you give dual anti-HER2, you optimize the pathological complete response. What are the best rates that we were able to achieve or to deliver? PCR 70%, which were achieved in several clinical trials. And the last one was the DREAM2 study giving vaccines, platinum, and the dual anti-HER2. And this is another slide showing us how patients who do not achieve PCR have significantly worse outcomes. They have higher recurrence rates, and the longer you wait, the longer follow-up of patients, you will find the higher the rates of recurrence. For example, in the HANA study, a longer follow-up of 6 years showed us 43% risk of recurrence. What about patients who do not achieve pathological complete response? So we said we can ablate, we can completely decontaminate these patients from cancer in around 70%, but we still have 30 to 40% who will not achieve pathological complete response. How we can improve the outcome? We've seen the data from the German group, the Catherine trial in 2017 or 18, where they showed that you can cut down by half, has a ratio of 0.5, the risk of recurrence, improving distant disease-free survival and disease-free survival by 50%. Therefore, again, this embedded TDM1 into the adjuvant setting treatment of breast cancer, and several cost-effectiveness studies show that it is a cost-effective trial. Nevertheless, TDM1, dual anti-HER2, proper anti-chemotherapy, optimizing the PCR, still we have a gap. How much is the gap? How much are the recurrences? Well, as I said earlier, a minute ago, the longer you wait, the more the risk of recurrences. So the trials which looked at 3 years outcome, 5 years outcome, you will see something around 10 to 15% of recurrences. If you went longer, like in the HERA, the BCRG, and the early breast collaborative trials group, where they looked at 8 and 10 years, you find recurrences up to 25 and 30%. So you give best treatment, you spend a lot of money on dual anti-HER2, you do best therapeutic approaches, yet almost a quarter of your patients are still at stake of recurrence. Another slide demonstrating the same. We're still awaiting the long-term outcomes from the Affinity and the Catherine, but we know, as I said, that the figures are around 25 to 33. And not all HER2 positive patients are the same. I've already shown you how the lymph node status can make a large difference in the risk of recurrence. And another important thing is the biology of the disease, the ER receptor status. So we know that HER2 from genomic profiling and genomic signature, not all HER2 positive patients are the same disease. If you look at the genotype rather than the phenotype, we will see differences. We'll find them, some of them, around 50% are truly HER2 enriched, but the rest are contaminated by basal-like patients and luminal patients, which we don't recognize by just the phenotypic test, the ER/PR HER2. You have to do full genomic profiling for these cancers to be able to tell of the intrinsic type. But we've known that patients who are HER2 and luminal, whether luminal A or luminal B, and most of them are luminal B if they are luminal, they do behave differently. I'll give you some evidence. So in the CT-NEO breast cancer pooled analysis, the Cortazar meta-analysis, they looked at patients who had neoadjuvant anti-HER2 and chemotherapy, who are ER positive and who are ER negative. And they found, as you can see from the blue bar, 30% pathological complete response in ER positive, 50% in ER negative. So ER indeed plays a role in the rates of pathological complete response and the event-free survival and the recurrence. This is the meta-analysis. The amber column on the right tells you that the rates of PCR in several clinical trials was less if the patient is expressing ER receptor in addition to the HER2. The most recent evidence on the same concept is from the TRAIN2 study. TRAIN2 was asking, shall we give anthracycline, not anthracycline? Forget about this question. What I want to demonstrate here is that on the left-hand side, the two bars who were ER negative had PCR 90%. So if you see a patient in clinic who is HER2 positive, hormone receptor negative, the likelihood of obtaining or seeing pathological complete response is almost 9 out of 10. However, in patients who are ER positive, HER2 positive, this drops down to 50%, which tells you that we're dealing with a cancer which is triggered, which is fired by two different domains, and there is interplay between the two receptors, the HER2 receptor and the ER receptor. And this confers different characteristics and different biology to the tumor. Why is this significant to us again? This is significant to us because almost 1/4 of our patients are HER2 positive, and a big chunk of our patients are not positive. So these patients will not do very well on neoadjuvant treatment, and they will have considerable risk of cancer coming back. So what have we learned so far from the past 10 minutes? That despite best treatments, we still have recurrences. Recurrences are inevitable, and recurrences are more in the node positive, especially in 2 and N3. And PCR is of paramount importance, and PCR is not as good if your patient is ER positive. Hence, we need to achieve better results. How we can achieve better results? We've seen, and you have read the recent literature of introducing TDXD, the ADCs, the TDM1. Now we have Datu coming on the way, to Catinib. So how did they perform? We're not sure yet. How do they do in the early stage setting? There are many plethora of clinical trials ongoing to try to bring this forward into the adjuvant and the neoadjuvant setting to see how we can rescue the 25-30% of patients that I'm talking about. But do we have something that is already approved that we can add to our patients to improve the results? Yes, we do. We do have an irreversible inhibitor of HER1, HER2, and HER4, that is the neratinib. The drug is not available in Egypt, but it is FDA approved and EMA approved. Essentially, it works. It's the same concept as lapatinib and tucatinib. So it's a tyrosine kinase inhibitor, small molecule tyrosine kinase inhibitor, works intracellularly, interrupting the signal transduction pathway. So all of these previous molecules, trastuzumab, TDM1, TDXD, they work externally on the surface. So this class of molecules, they work internally, and we've seen very good activity with tucatinib and lapatinib in the metastatic setting. Neratinib has been tested in the metastatic setting in more than one clinical trial. The most famous one is the NALA trial, and it showed high efficacy. It was better than lapatinib. So, as in other settings in cancer therapy, they bring in clinical trials these agents to earlier stages. So they've tested it in the XTNet trial, and in the XTNet it had patients who are HER2 positive, ER positive or negative. They've done all the necessary treatments, surgery, radiotherapy, chemo, trastuzumab, and then they opened, after the patient has completed all treatments, they opened 1 year of neratinib, which is an oral tablet, 230 milligrams for 1 year. The primary endpoint, it was a big study, it was almost 3,000 patients, and the primary endpoint was disease-free survival, invasive disease-free survival. They've seen 2% improvement in disease-free survival, and the 5 years, this was 2.5%. Not very great, yeah? 2.5 is not a major achievement. However, when they looked at the subgroup of patients, they found that the ER positive, HER2 positive patients, the patients that we are concerned about, they had a significant improvement by around 50%. Hazard ratio was around 0.60. And the absolute difference was remarkably better than the whole group. That's why the overall, if you put all the patients in one group, the benefit was modest. But if you look solely at the ER positive, HER2 positive, you'll find the absolute difference in the hazard rate, or in the absolute difference in the 5 years, the initial results, improvement from 85 to 90%. The hazard ratio, as I said, is almost 0.6, 0.58 to be precise. And this translated into an overall survival. Again, the survival was not very convincing when you look at the whole cohort of patients, but when they looked at the ER positive patients, they noticed the overall survival of 9%. So 9% in breast cancer patients, in non-metastatic breast cancer patients, is very convincing, and this is overall survival. The invasive disease-free survival, the primary endpoint, improved by 7.4%, and the hazard ratio is 0.6. This was a presentation in the last days, a few days ago, where there was a presentation, and Michael Nant and Martin Picard, they were talking about how important oncologists and training oncologists realize the importance of the relative risk and the hazard ratios rather than the absolute difference. Let me tell you a story that goes back 20 years ago. Aromatase inhibitors, anastrozole and letrozole, were FDA approved because of 1% improvement in disease-free survival in comparison to tamoxifen. But this was statistically significant, and the hazard ratio was 0.7 something. So the absolute difference, as presented in this discussion, for example, tells you that it is important to look at the hazard ratio. And the hazard ratio in this trial, as I said, in the correct group of patients was 0.5. You decrease the risk of mortality of patients by giving this agent after proper anti-HER2 for 1 year. Some might argue that giving an expensive treatment for 1 year, in addition to previous treatment with chemotherapy, is a long chore for patients. That's a long journey for patients. But let me remind you of a very recent story. We all now discuss with our patients adjuvant CDK4/6 inhibitors. The Monarch has established this, the Nathalie is on the way. What did these studies show us? They showed improvement in disease-free survival, less than what we have seen in the XTNet study. That's point number one. Point number two is that we do not have overall survival data for these patients. What we are doing, we're offering patients tablets for 2 years, very expensive. They are convincing. I offer them to my patients personally. But what I'm saying is that neratinib, if you compare this to that, well, neratinib does the same in addition that it's 1 year only, or 2 or 3 years. Plus, it showed overall survival improvement, unlike the CDK inhibitors, which we are now convincing our patients to receive for 2 or 3 years. And the most important thing is overall survival. It's not the primary endpoint in most of the adjuvant studies because it takes a long time and there are other confounding factors. So we like to look at disease-free survival, but for this study, we have overall survival improvement. And this is the most important to our patients. Other ratio, as I said, 0.47, so very convincing. What are the most common side effects to this agent? Like the rest of the tyrosine kinase inhibitor, sunitinib, pazopanib, etc. They cause sometimes skin reactions, dermatitis, diarrhea is one of the most common side effects. So you have to be aware if you're using it. It's probably still not available in Egypt. Hopefully it will be available soon. But you have to be to keep diarrhea at the back of your mind, give preemptive measures, do some good counseling to the patient. What are the caveats about the trial? The trial was conducted a long time ago, before the era of TDM1 and TDXB. So what they've done is that they offer this treatment after an adjuvant treatment with pertuzumab. Now we have pertuzumab and we have TDM1. So what are the outcomes like? We don't know. But does this negate the use of this agent after these treatments? Well, probably not. Why? Because first, I've shown you in the 2 previous tables that despite using the best treatments, we're still having at 3 years 10 to 15% of recurrence of patients. This figure increases with N2 and N3 patients, which are higher among our patients. That's number one. Number two, in many instances in oncology, we cannot replicate the same trial after each introduction of a new treatment. And this is the discussion ongoing, for example, in the HER2 low patients after TDXD came into practice. Well, shall we give SG, sacituzumab govitecan? Shall we repeat all the trials when each molecule comes into practice to see if the new molecule will perform or not? I'll give you another example from the Lumina. Everolimus was tested as a second line after aromatase inhibitor. We're all using, and all the guidelines are incorporating everolimus after CDK. Do we have evidence of using everolimus after CDK? We do not. However, we all offer CDK after, everolimus after CDK. So many examples, I can list dozens of examples. We don't need to replicate all of the clinical trials in order to tell how much exactly the benefit of adding this agent. There was a study which is called Alienor study. It's an observation prospective trial which looked at what oncologists in Europe are doing for their HER2 positive patients. So they looked at 300 patients, how were they treated nowadays. And they found that actually oncologists who offer trastuzumab or dual anti-HER2 in the adjuvant or in the neoadjuvant and TDM1 in the adjuvant, most of them, they offered neratinib still, particularly in patients of high risk. These are the stage 2 and 3, and patients who are ER positive patients. The pie chart on your right, it shows you why they chose neratinib. Most of them were convinced by the clinical efficacy. This is a publication in the Breast Journal last year by Nadia Habek, where she demonstrated her approach and oncologists at her center, and it shows you that neratinib for 1 year at the very bottom of the slide were offered to patients with ER positive, HER2 positive, particularly in patients who did not achieve PCR and HER2 positive patients. These are the AGO, the Dutch breast cancer guidelines, and they incorporate neratinib into their adjuvant setting nowadays in 2023. I've used this agent only in a couple of patients in the UK because it has been approved there since 2017. This is from the NHS of the Royal Surrey Hospital. And as you can see on the bottom right, the left-hand side of the trial, that neratinib, we have access to offer neratinib to patients after anti-HER2 therapy. So my conclusions for today, patients with HER2 positive early breast cancer at high risk of recurrence despite all the advancements. I haven't touched on CNS efficacy of the agent for the sake of time, but it has high CNS efficacy. In patients with PCR, who continue the neoadjuvant, they are the better outcomes. However, you can improve the outcomes even more with neratinib. But indeed, the patients with non-PCR and those who are not positive, they require an extra layer of adjuvant treatment to reduce the risk of recurrence. Neratinib can help in this setting. Thank you very much.
Thank you, Professor Ahmed, about your earlier presentation. Any question from the floor? I want to discuss you about, Ahmed, you know that there is many players from INFO. You can proceed with your question. So, Iman, you can take my...
Thank you, Dr. Hamad, for this elegant presentation. I want to ask a question. What about neratinib if employed in new adjuvant treatment for patients with high risk HER2 positive and hormonal receptor positive?
Neoadjuvant.
Yes. Why we didn't give it with the dual targeted therapy so that we increase the pathological complete response, we prevent the relapse, we improve the survival?
Well, we have literature, but not with neratinib. I'm not aware of the data with neratinib. There might be some earlier phase trials. Or we have trials with dual anti-HER2 blockade with lapatinib and trastuzumab in the neoadjuvant settings, and the results were positive, but they were not optimal. The best PCRs came with trastuzumab, and neoadjuvant chemotherapy from the GPAR-6 train, and all of the literature will show that if you combine chemotherapy and the dual anti-HER2 trastuzumab. But we have with the lapatinib data, and actually some argue that you can offer this to patients who are not fit for chemotherapy. And there are multiple German trials which are actually looked at avoiding chemotherapy, frank chemotherapy, and giving TDM1 with hormone therapy. And they obtained reasonable pathological complete response rates. However, again, it's not as good as when you build the full package of chemotherapy and dual anti-HER2.
Dr. Ahmed, I want a question for you, please. We have a new player after neratinib that's to give in adjuvant setting or neoadjuvant setting. We have nowadays TDM1 for the neoadjuvant setting, for the adjuvant setting after Catherine trial. What's the exact position of neratinib in the era of TDM1 disease at Catherine trial? Because we see that many experts in ESMO recommending neratinib post TDM1. Do you have a subgroup population of patients needing this maintenance treatment? Maybe the bulk
overall survival will be a 9% after TDM1, or will it be less, or it will be negated completely? We're not sure. But there will not be a clinical trial to try to replicate this study or the other studies with each introduction of a new molecule. This is what's happening in other settings, as I said, in the Afinitor example and in the SG, TDXD. They will not do a sequencing to find the best sequence of treatments. So if you have a molecule that you can add as an extra treatment to treatment 1, which is good, and then you have treatment 2, which is better than treatment 1, put it and still add the extended, because it does not compete with the TDM1 or the DXD in the future. Yes. It adds an extra layer, as I said.
Yes. We were there in ESMO in this conference, and they highlighted that patient with maybe hormonal positive or triple positive with bulky disease after neoadjuvant treatment may need to extend the treatment after TDM1.
Yes.
Yes.
This is the group which is the highest stake, and
yes.
these are the group of patients who will benefit the most. That's why in the NICE guidelines, for example, when they justified giving neratinib, they justified giving it this particular population of patients.
Yes. Thank you. Doctor, we so want to close this ceremony. Thank you for your attendance. Thank you for Dr. Ahmed for your elegant presentation. Thank you for that time. Thank you.